Hello, I'm Dr. Karuna, obstetrician and gynecologist at Akkineni Hospitals. I hope you're doing well. Let's explore some important insights today. Please stay tuned and make notes.
Hey everyone, and welcome to this explainer. Today, we're going to tackle a topic that is absolutely critical, yet honestly, incredibly misunderstood: diabetes during pregnancy. Look, it's a subject that can bring a whole lot of anxiety to expecting moms and their families, but understanding the science behind it, that is the absolute best way to manage it. In this explainer, we're going to demystify this complex relationship between pregnancy and diabetes. We'll break down the biology, the risks, and most importantly, the highly effective, actionable strategies used to protect both the mother and the baby. So let's get right into it.
Here is our roadmap for today. We'll cover the two types of diabetes, the placenta and insulin resistance, risks to mother and baby, screening and diagnosis, managing gestational diabetes, and finally, handling pre-existing diabetes. All right, part one, the two types of diabetes, gestational versus pre-existing. Okay, let's dive into this. The absolute first thing we need to wrap our heads around is that diabetes complicating a pregnancy isn't just one big monolithic condition. We're actually looking at two entirely different timelines here. First, we have gestational diabetes mellitus, or GDM, which is glucose intolerance that is first identified during the pregnancy itself. On the flip side, compare that to pre-existing diabetes. That's when a mom already had type 1 or type 2 diabetes before she even conceived. So while both of these require very careful, specialized management, they represent two totally distinct biological starting lines. Moving on to section 2, the placenta and insulin resistance. Basically a massive hormonal tug of war.
To really get gestational diabetes, we've got to talk about one of the most incredible and honestly demanding temporary organs in the human body, the placenta. It doesn't just sit there passing nutrients. It actually acts as a highly active hormone factory, pumping out things like human placental lactogen, progesterone, cortisol, and growth hormone. And this brilliantly illustrates a physiological tug of war. See, these hormones naturally induce insulin resistance in the mother. Why? To make sure plenty of glucose gets redirected straight to the growing fetus. It's a brilliant biological design, kind of like a rogue organ temporarily taking over the body's systems. But it demands a massive amount of extra insulin from the mom's pancreas just to compensate.
So what happens when the mother's pancreas just can't keep up with that hormonal tug of war? Well, that's when we see conditions like gestational diabetes develop, and it is incredibly common. To put this into perspective, GDM affects 10 to 15% of pregnancies in India, making it one of the highest rates in the entire world. When you combine a limited pancreatic beta cell capacity, which, by the way, is often tied to South Asian genetic susceptibility, with this intense insulin resistance, the compensation simply fails. Toss in things like modern dietary patterns and rapid urbanization, and maternal blood sugar starts to rise, typically peaking right around the second trimester. Which brings us to section 3, risks to mother and baby. We really need to understand the stakes here. Now I want to shift to a serious but optimistic tone here, because understanding the exact stakes of uncontrolled glucose is precisely how we prevent these negative outcomes from happening. The most immediate consequence we look out for is something called macrosomia. When mom's blood sugar is high, all that excess glucose crosses right over the placenta. The baby's pancreas responds to this by producing extra insulin. This state of fetal hyperinsulinism acts just like a massive growth hormone. It drives excessive fetal growth, resulting in a baby weighing over 4 kilograms, which is almost 9 pounds, and it specifically targets the growth of the baby's shoulders and trunk. And as you can imagine, that excessive growth leads to a whole cascade of potential birth complications. Macrosomic babies face significant birth injury risks during delivery, including shoulder dystocia and even bone fractures like broken clavicles. But the risks don't just stop at delivery. Think about it. Once the baby is born, that massive supply of the mom's glucose is suddenly cut off. But the baby's pancreas? It's still churning out all that extra insulin. This can lead to a sudden, dangerous drop in the newborn's blood sugar, known as neonatal hypoglycemia. In severely uncontrolled cases, there is an elevated risk of respiratory distress syndrome, and tragically, even stillbirth. And looking way down the road, this high-sugar environment in the womb literally programs the child's metabolism, significantly increasing their lifetime risk of childhood obesity and type 2 diabetes. But it's not just about the baby. The mother faces some really high long-term stakes as well. Women who develop GDM have a staggering 50 to 70% lifetime risk of eventually developing type 2 diabetes themselves later in life.
Gestational diabetes isn't just a 9-month hurdle. It is a major, lifelong metabolic warning sign that requires moms to undergo routine checkups for years and years after the baby is safely delivered.
Okay, let's move to section 4, screening and diagnosis. This is our universal intervention. Because those lifelong stakes are so high, catching this condition early is a universal health intervention that can change the entire trajectory of the pregnancy. The guidelines from DIPSI, that's the Diabetes and Pregnancy Study Group in India, strongly recommend universal screening for all pregnant women. This is absolutely a non-negotiable part of modern prenatal care. The standard protocol uses a 75-gram oral glucose tolerance test, usually given between 24 and 28 weeks. However, and this is an important point, for women considered high risk, this screening should actually happen as early as their very first doctor's visit.
So the crucial point here is understanding the exact number we're looking for. According to DIPSI, when you take this non-fasting 75-gram test, if your 2-hour plasma glucose level hits or exceeds 140 milligrams per deciliter, that officially confirms a gestational diabetes diagnosis. That's the threshold. All right, Section 5, Managing Gestational Diabetes. Let's look at the step-by-step solutions.
Once we have that diagnosis, it's all about empowering the mother with actionable step-by-step solutions to regain control and protect her baby. Management involves escalating tiers of lifestyle changes. Step 1 is the absolute foundation, medical nutrition therapy. We're talking about a carefully carbohydrate-controlled diet that limits the overall glycemic load, spaces out those carbs evenly across meals, and totally ditches refined sugars. Step 2 introduces moderate aerobic activity. Literally something as simple as walking for 30 minutes right after meals can massively improve post-meal glucose levels. And Step 3 is strict, ongoing glucose monitoring at home, just to make absolutely sure these lifestyle tweaks are actually getting the job done.
And when I say strict, I really mean strict. Notice just how incredibly tight these target numbers are compared to normal, non-pregnant guidelines. The mom has to monitor herself to make sure her fasting blood sugar stays under 95. 1 hour after eating, it has to be under 140. And 2 hours after a meal, it needs to be under 120. Hitting these precise, strict targets is exactly what keeps that fetal environment safe.
But look, sometimes diet and exercise just aren't enough to beat the placenta's hormones. And you know what? That is perfectly okay. Let's look at the numbers. Roughly 30 to 50% of GDM cases in India will end up needing insulin therapy to maintain those tight targets. We really need to normalize this medication. It's just a critical tool in the toolbox. In some clinics, doctors might use off-label oral drugs like metformin or glibenclamide if insulin isn't a good fit, but insulin remains a highly effective gold standard here.
Finally, Section 6, handling pre-existing diabetes. This requires a very proactive approach. Handling pre-existing diabetes builds on everything we just talked about, but it demands an even more aggressive, proactive strategy. For women who already have type 1 or type 2 diabetes, the planning literally has to start before conception even occurs. Getting that HbA1c level below 6.5% prior to conceiving is an absolute necessity. Why? Because high blood sugar in early pregnancy is incredibly dangerous. It massively spikes the risk of severe congenital malformations in the developing embryo, specifically devastating cardiac and neural tube defects. Because of that, the clinical protocol for pre-existing diabetes is tough. It includes starting on 5 milligrams a day of high-dose folic acid well before getting pregnant. Once conception happens, those glucose targets we talked about become significantly tighter than what the mom was used to as a non-pregnant patient. Furthermore, because that placental insulin resistance will predictably keep ramping up, the mom's required insulin doses are going to skyrocket throughout the second and third trimesters. It's just a biological given.
But here is the ultimate, most important takeaway, supported by the clinical framework at institutions like Akkineni Hospitals. Excellent outcomes for both the mom and the baby are highly achievable. It's totally possible. It just takes a highly coordinated, multidisciplinary team. When obstetricians, endocrinologists, and dietitians all work together with the mother, utilizing intensive glucose monitoring and dedicated fetal surveillance, well, mothers with diabetes can and do deliver perfectly healthy babies every single day.
Which leaves us with a truly mind-bending biological question to ponder. We've just seen how a temporary organ like the placenta can trigger an insulin resistance so intense that it permanently rewires a mother's lifetime metabolic risk for type 2 diabetes. So, it forces us to ask, how else might the 9 months of pregnancy permanently shape our long-term health long after the baby is born?
Pregnancy isn't just an isolated event, it is quite literally a window into a woman's biological future. Thank you so much for joining me for this explainer. I really hope this cleared up the vital intricacies of diabetes and pregnancy. Keep questioning, keep learning, and I'll see you next time.